Great. Well, thank you so much, Lisa, and welcome to this webinar we have today on the digital revolution of healthcare. When Lisa first conceived of this idea back in March, we were really excited about the topic, but of course we had to hit the pause button like everyone else when COVID arrived. And we've been noodling about how to bring this amazing panel back to our alumni community. And we're proud to say that today's webinar is the result of that hard work. And Lisa Katzman, who is a fellow board member, gets all the credit for that. We have over 300 people that have signed up for today's webinar. So we're very excited to have such a large group, and also extremely excited to welcome two other groups to the Penn community today. The Wharton Club, the National Capital Region, and President Nargis Samani, and the Columbia Club of DC, with whom we partner often, and their excellent president, Kambiz Ranavardi. So welcome to both of you, and also welcome to all alums from those two different communities. We're extremely excited today to talk about this event. As I mentioned before, we're going to have an amazing panel, which Lisa is going to be introducing in a second, and also an expanded conversation around the digital revolution in healthcare as it relates to the corona pandemic. Just a quick programming note: we will have more events coming in the next several months as we kind of review our slate, and we are very interested in hearing ideas if you have ideas for events as well. So before I hand it over to Lisa, I just wanted to remind everybody that today's panel and webinar is going to be recorded, which will also be distributed to folks via the websites of the various alumni clubs after. So without further ado, again, as president of the Penn Club of DC, I thank you for joining us today. And Lisa, thank you for doing such a great job, and over to you.
Great. Thanks, Todd. So another housekeeping note is that you can submit questions via Q&A, not through the chat. So I'll be reviewing them, and we will do our best to get to as many as the questions as we can on the call. So today's topic is: how has the digital revolution of healthcare been accelerated by COVID-19, and how will it factor into our return to a new normal? We'll discuss the digital revolution's jumpstart due to the pandemic, its overall positives, greater access to affordable and safe distance healthcare, more comprehensive picture of the patient with linked medical records, predictive artificial intelligence for better patient outcomes and diagnostics, and potential negatives like privacy and security exposure, digital learning curve, and the depersonalization of medicine. Many professionals in the healthcare IT space, like myself, and frankly all of our panelists, earn their keep guiding hospitals and health systems to manage the digital revolution of healthcare, and really to harness the associated big data and wade through the policy issues. So I've got a few slides here I wanted to share. In talking to Sunil and other experts in the past, we really know that healthcare as an industry is especially susceptible to digital disruption. There's the innately complex nature of hospitals and healthcare systems itself. Did you know that the typical number of IT systems at hospitals is over 800? Of course, there's an increasing consolidation environment, mergers and acquisitions. There's HIPAA privacy requirements that have come to the fore, the need to safeguard medical data, and the influx of new and more data inputs, such as telemedicine, wearable devices. Next slide, please. So, according to experts in healthcare, there are 5 important trends we should be familiar with at this time. So there's remote patient monitoring, such as wearable devices and things you get sent home with from the hospital and your doctor. Artificial intelligence, especially for using the data for predictive analytics. Electronic medical records reform. Voice activation at a hospital setting, such as using Google Docs in the patient rooms. And advanced analytics to identify and rate effective healthcare providers. So we're going to hear today how digital medicine, contact tracing, and AI will factor into our return to work and school plans and help us manage the tsunami of current behavioral health and wellness needs. Also, our panelists will tell us what's happening with routine diagnostics like diabetic monitoring that seem to have been gone by the wayside during the pandemic, unfortunately. So we're so fortunate to have with us three panelists who can offer frontline and varied perspectives. I'm going to introduce them. As for myself, your moderator, I'm Lisa Katzman, Penn College 87, and my professional role is as Director of Marketing for OptiSave, a healthcare IT advisory firm specializing in cost reduction and performance improvement. On to our panelists. Chris Brandt, Wharton grad 2008, is a technology business founder and AI expert. He's the founder and CEO of Audacious Inquiry, an information technology and policy company focused on connected healthcare. Sunil Budhrani, College 95, is a top healthcare provider and hospital executive. He's Chief Executive Officer at Innovation Health, a first-of-its-kind partnership between Aetna CVS and Innova Health System, providing health insurance services to the DC metro region. And finally, we have Genevieve Morris. She's a long-term policy expert and consultant, the owner of Integral Health Strategies, Health IT, and Strategic Consulting Services. Besides the topic at hand, as time allows, our experts will discuss the potential for COVID resurgence and the search for and implementation of a vaccine program. So at this point, we'll stop screen sharing as we open the panel discussion. Okay. I'm going to kick off with Sunil. Sunil, as a practicing ER doctor as well as an executive, will you share with us your clinical perspective on how healthcare's digital revolution has accelerated due to COVID-19, touching on telemedicine, remote monitoring, and the positive and negative impacts on patient care, COVID and non-COVID? Have we really been able to stay in touch with patients as effectively remotely as in person?
Sure. And again, thank you for having me here, and look very much forward to the panel with the other experts on this discussion. So thanks again, and hope this really helps the community. Before I address how I think the digital pace has accelerated greatly, I think it's important to understand some baseline, at least in this region, since most of us that are attending today are from the DC metropolitan area, to understand our regional landscape. Bearing in mind, there are significant differences across the country in terms of how we are responding to coronavirus, COVID, based on how we have progressed through different phases and recurrences and resurgences and so on. So in the DC metropolitan area, to just lay the landscape out, we've had about 60,000 cases in the state of Maryland, about 50,000 cases in the state of Virginia, and in the district, about 10,000 cases, for a total of about 120,000. So what that essentially tells you is, in all of those areas, we have seen a significant plateauing or decline, for the most part, of cases in our region. Now, when COVID had hit early on, to your point, Lisa, we were on a shutdown, lockdown mode, a stay-at-home mode in almost this entire region. And I'll talk a little bit about how we've advanced into phase 1 and phase 2 now. But when we were on this stay-at-home mode in this region, because we really didn't understand the prevalence or the number of cases in the area, what was occurring was there was a shutdown of the health system in many ways also. And what I mean by that is elective cases, those procedures you were scheduled for, most doctor visits, most dental visits were stopped because we wanted to make sure we have the resources, both staff and personal protective equipment for any potential significant rise in COVID that would inundate our healthcare system in this region. So because doctors' offices and hospitals that were doing their scheduled visits were stopped, everybody was kind of scrambling to try to figure out how to keep the healthcare business and system and people safe. A part of that was what you termed earlier was a significant pace of digital tools, namely telemedicine. Aetna Innovation Health, along with many other payers across the country, relaxed their standards when it came, and their reimbursements and their co-pays and all the barriers related to all of those things to allow for telemedicine to occur. There are three types of telemedicine. There's the on-demand, I need to see my doctor for an acute care or urgent care visit now, what I call the acute type of urgent care type of visit, where co-pays were completely removed for the most part as it relates to COVID, and doctors were paid on par as though they came in and saw a patient face to face. This was a major inflection point for telemedicine. As you know, I chaired the American Telemedicine Association guidelines for telehealth in 2013, and we had been waiting for a wake-up call on the utility of telemedicine. With the removal of the obstacles when it came to the financial barriers like co-pays to telemedicine, and then paying doctors on par like an office visit, and then also relaxing some of the state requirements when it came to delivering a telemedicine visit. Traditionally, you had to be a licensed doctor seeing a patient in your state that resided there to do a visit. A lot of those rules, depending on whether you were Medicare, Medicaid, or a commercial patient or so on, were relaxed because we needed to make sure this resource were available to patients when they couldn't physically come see their doctors. So that was a significant, companies like us saw a 5, 10, 15-fold increase in the use of telemedicine in the way I described, that video visit on a telephone or a laptop when you needed to see your doctor. Now, the other thing that was very interesting that got relaxed, and this was done at a CMS level, was they relaxed the idea that you needed to necessarily have a HIPAA-compliant, certified video tool to conduct that visit. You could do a telemedicine visit one-on-one with a tool like Google Hangouts, Facebook Messenger, WhatsApp video. You could use other tools that were not really permitted before. So this advanced significantly the volume of that type of telemedicine visit. The two other buckets of telehealth were the remote patient monitoring, which is traditionally used in a chronic disease type of format, where a patient will have a device. It could be a Bluetooth glucometer. It could be a Bluetooth scale for heart failure. It could be a Bluetooth device to measure an asthmatic's breathing capacity. And you could essentially monitor a patient remotely for their chronic disease. And the codes to bill for those procedures were relaxed and in the same way so that we could make it monitor patients. And then the third component of what I call telemedicine, which is the on-site clinic, where you have carts, literally with multiple devices coming off them, where a device could be placed on a patient, like a stethoscope or an otoscope or something to examine the mouth, and a doctor on the other end could be able to monitor that patient. And the CVS Minute clinics, you may have heard, were doing these kinds of very on-site e-clinic types of exams on patients to be able to provide that sort of care. But all of that advanced so rapidly in the last 3 months to provide that level of care in light of this resurgence, in light of the growth and the number of cases that occurred.
And just one or two things to jump in on the telemedicine. I think Sunil brought it up that currently the HIPAA requirements are relaxed, which basically just means that OCR isn't enforcing HIPAA, right? So HIPAA is still in effect, but they won't actually investigate or levy penalties if people aren't following it. And so I think what's going to be interesting with telemedicine moving forward is a bunch of people jumped on board with technologies that are not HIPAA compliant in order to meet the really quick demand for telemedicine. But once that order is rescinded, so once HIPAA is back in full effect, you can't just keep using Facebook Messenger or Google Hangouts unless they come out with a HIPAA compliant version. And I think Zoom already has come out with a HIPAA compliant version because they saw where this was going. Shockingly, I think Zoom has benefited the most from this shutdown. But so it's going to be interesting to see how people transition, because I don't know how many folks on the front lines are going to be aware that what you're using for technology today that's not HIPAA compliant and is okay, in probably about 3 or 4 months is most likely not going to be okay for you to keep using. Because I'm guessing like the order from HHS is probably going to be rescinded, I would guess, in the next 3 to 6 months, just based on the fact that we won't be under a state of emergency anymore. So that's, I think, going to be interesting. And then the second thing, and Sunil mentioned this with CMS changing the guidelines somewhat. The other big change they made was that you could do a telehealth visit with a patient who was a new patient. So prior to this, in order to get reimbursed, the patient had to be an existing patient, and then you could do a telehealth visit with them moving forward. And they modified that requirement so that you could, in fact, with a brand new patient, do a telemedicine visit, with the idea being that the doctors that patients usually go to aren't necessarily available. And so you have doctors who can do telemedicine who can now see those patients, particularly those with chronic conditions, and help them. The downside of that is that they put all that policy into place without accounting for doing any type of identity proofing or management at all. And so we now have a situation where we have this great policy that's expanded telemedicine, but we don't have the infrastructure or the technology in place to make sure that the patients using the services are actually those patients and that the data they're getting access to is their data. And so it's great that we have all this telemedicine, but now we like opened this whole other can of worms that we haven't yet dealt with. And we will have to, I think, over the next year, really, in order to make sure telemedicine keeps moving forward.
Right. Thank you for giving us that level set, Sunil, and for that policy perspective. Really a lot of things we've never dealt with before. I'm going to jump to Chris now for a question. Chris, can you share the ways that you see artificial intelligence really helping us to return to a new normal, whether it's for screening or contact tracing? How will it factor in?
Hey, thanks, Lisa, and good morning. I'm excited to be here. Glad to talk a little bit about healthcare digitization and the way we've seen it used in response to the crisis and in our effort to move back to the new normal, like you said. I'm most familiar with healthcare interoperability, so I'm going to start there. So healthcare interoperability, or health information exchange, is the technology behind moving clinical care data to the right place at the right time. So by way of example, notifying a patient's primary care doctor, such that they can actively engage their patient during or following a hospitalization. We know that is one of the most effective methods to improve healthcare quality outcomes and reduce the total cost of care. So that's an example. But we found that during the current crisis, interoperability technology and health information exchanges help to enable some really important public health use cases. So, situational awareness for policymakers. So think, resource utilization, ventilators or hospital beds, syndromic surveillance. So monitoring the spread of the disease and how is this impacting certain populations more than others. Informing caregivers at non-traditional sites like a testing center or convention facility if it went online, or a hospital ship. So getting that sort of complete record to those places. Sunil touched on some other digital health technologies that have been super relevant during the crisis, and Genevieve did as well. Telemedicine and remote patient monitoring. This hospital at home model that Hopkins, I know it's being deployed at Penn, now. They've been deployed out of necessity here. Many think their prevalence is kind of here to stay. As Genevieve said, maybe they need to be modified. We've got to do some credentialing and other things to enhance them. But we're meeting the patient where they are. And for a lot of encounters, this is great. Than waiting in line at in an office somewhere, waiting in a waiting room. You asked about artificial intelligence. AI and machine learning are super cool tech, extremely promising. It's just still on the edges of what we need to do in healthcare right now. I think the commercial failure of IBM Watson is an example here, sort of like, it's an example here. It's, I just, my sense, and again, other people have different opinions, but, rather than focus on the coolest tech, let's focus on getting real-time data to providers and payers right. Let's focus on policies and technology that allow us to meet the patient where they are. Let's focus on preventative care and upstream services and getting incentives aligned with patient outcomes and public health. That's sort of my sense on that. And then, lastly, you asked about contact tracing, in terms of, it's sort of a technology that is, that is talked about as a way to move us to the new normal, right? And so it's super interesting. There's a national conversation in the US and elsewhere around contact tracing, including technology developed by Apple and Google. And, it's this trade-off to be evaluated sort of between the extraordinary capability of the technology to improve public health and stop the spread of the disease, and our personal interest in privacy and security, and not really getting the government or large monopolistic businesses to know where we are and who we're meeting with all the time. So I would defer to Genevieve here, frankly, to opine on the sort of on the policy front of that, to the extent you want to take that, Genevieve. But
yeah, it's a brave new world, and I'd love to hear what Genevieve has to say about it, policy-wise.
Yeah, so I think it's a couple things all happening at the same time. So those of us who've been in the field for a while know that contact tracing is something that we've done for years and years at a really small scale for particularly sensitive health conditions like HIV to monitor the transmission. I think what's been fascinating during COVID is the fact that the general public has now become aware that we have public health agencies in every state who do this type of contact tracing. And it could just be the groups of people that I hang out with, possibly, but like the general public is like super creeped out by it for the most part. Like if you're in the healthcare field, what I found is like you're totally fine with it because you understand sort of why it's being done and what the overall goal is. If you're not in the healthcare field, you do not feel good about this because it's the idea that our government is tracking us, which I don't think any of us actually feel that great about. And we've seen this pick up in other countries, right? Like China by far is doing the most with this, with the facial recognition services. And I have friends who live there who have an app on their phone, and every time they leave their apartment complex or go back in, they literally have to check in and out on the app on their phone so that they can track them where they're going. I don't think any of us actually are okay with that here in the US. And so we are seeing this massive collision of public good and public health versus the right to privacy. And where we're really struggling in our country is HIPAA is still by far the only privacy legislation we have. I mean, you could say some of the breach notification stuff with an FTC falls under that, but like HIPAA is still pretty much our only privacy law. And at last count, we had 19 different bills floating around Congress around new privacy frameworks, some of which include health, some of which don't. There are definitely various opinions in the industry on whether healthcare needs an overhaul. I think it does, because where do you draw the line at what's health data and what's not? Because our current line drawing is like covered entity or not. And that's really just not doing it for us. Because like Apple and Google are not covered entities. Any health data they have of yours, they can do whatever the heck they want with it. And that's, I don't think, very great for our privacy or for long-term around marketing and things like that. So we have this debate going on that the general public is starting to get involved in, but Congress is still, frankly, just really far away from doing anything about this because they can't agree. And like, it's just super odd because if you, and I get that not everyone tracks legislation because I'm just a nerd around this stuff, but like the roles around what you would think left and right would be on privacy law are totally reversed from what you would think they would be. Like the Democrats want states to be the ones setting all of their own privacy laws instead of the federal government. And the Republicans are like, federal government should set that. And then Republicans are weaker on privacy and the Dems are more strict on privacy. And so it's this weird role reversal between the parties that you wouldn't necessarily anticipate prior to this. And with that many bills floating around, I think it's just going to be a while before we actually get somewhere with it. But, you know, the contact tracing is concerning. You know, I have my own concerns about it because I don't know that the government should know where we are all the time. I don't know how I feel about Apple and Google because they have no rules on what they do with that information. I think it's good that they're limiting the APIs to public health agencies, but there's also this group of companies and organizations pushing for them to open that API for the contact tracing wider and broader. And so you're seeing that conflict there too. And then like the second thing that's going to come, and I have clients who are actually working on this, is the concept of like a health passport or a health pass, where you on your phone, you show like, I either have the immunization when we eventually get one that we feel is safe, or I've been tested with the antibodies and I'm clean, or, you know, like that kind of thing. Clean is probably not the right word to use. That's a weird tone for the conversation, but I don't have COVID is probably the correct terminology. And so that concept of a health pass, other countries like the UK and some of the European Union countries have already started working on that concept of a health passport and are starting to put it into place. I think it's Estonia, the one that has the blockchain stuff, is pretty far along with that. And there are multiple companies here in the US who are working on the same thing. And I think there's like multiple layers to this, like I mentioned with the telemedicine, where it's like, it starts with identity proofing. Like, how do I know that you are who you say you are? How do I then match up your test results or your vaccination to you to know that it really is you? And then who are we comfortable with having that data? Is it a company that I choose that gets to have that data, who can identity proof me and like keep my data secure? Is it the government that gets to have that data and this goes into your passport that you scan? Like those are really significant questions that I think we just like breeze over. And I think the concern I have is, one, we don't have consensus on the policy around that, around who gets the data and how much control do I have. And then we're missing some of like the fundamental infrastructure necessary to do some of that, particularly around things like federated identity management, where you are you across everything. And I know that it's you, not just because you have a username and password, but because I know it's you. And that starts to get into like biometrics and all that kind of stuff. And so it gets scary really fast. But it's complex, and there's a technology problem and there's a policy problem. And in the midst of like trying to get everyone back to work, we're sort of just like not talking about those things, and we're pretending that they're going to work themselves out. And I think consistently what we've seen in health IT is like that stuff doesn't just work itself out. It just keeps snowballing.
Yeah.
It ends up like,
So
you know,
it's really fascinating.
It is. And you spend your whole career working on this stuff and get nowhere because we just refuse to address the underlying issues.
So that's very interesting. Yeah, that brings me to a question that I was chatting with Sunil about a few days ago. And Sunil, I want to hear from you. We often do hear cases where hospitals merge and or they're just adapting new IT systems and not properly sunsetting the old ones. So we're really left with a patchwork of IT systems, and you know it's kind of glommed together, and it's a little bit scary. What do you think are the implications of that? What's the danger?
Yeah, I think that the pandemic has highlighted and emphasized its flaws in the healthcare system in the United States in a very rapid way. Things we all knew were problems, including the one you just mentioned, have been further highlighted and emphasized during the pandemic because it stressed our system. What I mean specifically behind that is, I always say, you know, there's this comment that we have the best healthcare system in the world in the United States. And being an ER doctor in the ER at GW and then running the health plan for this region, I can tell you what has become very clear is we are a really great healthcare system when you are suffering from cancer or have a heart attack or a stroke. But what this has illustrated is, we've known this, is we're not really good at preventing diabetes. We're not really good at preventing heart disease and stroke. And we certainly, at least in a lot of experts' opinion, have a lot of work to do on public health. Prevention and public health has been shown in this pandemic to be areas of opportunity for improvement. I applaud the work. Chris and I have crossed paths over the years in different roles I've had. I applaud the work of Health Information Exchange. And he's done great work in the region for us in advancing that initiative. But as Genevieve mentioned, one of the things that we have seen, like Singapore and South Korea, the hospitals were in discussions with them very early on. And their systems, their IT systems, have been very coordinated for a very long time. Their public health departments, their private health departments are connected such that if you go to a hospital or you go see your doctor, that information is shared in a way that is very different than how we share information in the United States. And what that lets you do, and to Genevieve's point, we have some very sacred views of privacy that are very fair and real. But they've allowed those cultural differences that other countries have demonstrated, like South Korea and Singapore, where their citizens have said, if I have COVID, I'm okay with that information being on a phone. And if I'm near somebody with COVID, I get an alert. That kind of discussion is culturally acceptable in those countries and have helped them get through this pandemic in a way that our cultural norms are going to be challenging. So legacy systems in hospitals is an example of what I'm talking about. Years over years, we've put medical records into hospitals. We've upgraded them, and then we've upgraded them again. Not many hospitals have had the resources because the cost of implementing a medical record system is so huge, it's bankrupted health system to explore other ways of connecting data. So what that's done is it's created building new systems on old systems, which leave gaps in the overall continuity of care. It also creates a vulnerability for cyber attacks, which was something I was talking about before COVID a lot more. But right now, as I had touched upon, it's kind of broken, legacy systems building upon each other, entities keeping data to themselves. That has highlighted the weaknesses we have as a healthcare system in this country in this pandemic that we're living. I will just say one more thing. When it comes to contact tracing, because it's just overused term, I believe there's 3 components to get people back out into society. We have to believe we will coexist with this virus at least through the end of the year. So a vaccine's not going to be available until later 4th quarter, and in any mass quantity, it's not going to be available to first the most vulnerable, the high risk, and healthcare workers. So we're not going to immunize this country at any major quantity, at least from what we're seeing so far, even though tons of resources are being put to this, until the end of the year. So what that means is we are flying what I call blind in many ways. We didn't, for many reasons, didn't test aggressively early on. So we don't have the cleanest understanding of the prevalence of what's out there. So 3 pieces are necessary for us to get back out. One is testing. So testing has aggressively occurred. But it's number 2 is contact tracing is the second component to understand the prevalence and how much it's really out there, and then identify the positives, tell them to quarantine, any family members or colleagues to do the same, but track those people in a meaningful way. And then the third is creating new environments for people to go back to work. That means new office building type spaces with lanes and cubicles spaced out, frequent disinfecting, temperature checks, mask wearing, all of the above.
Right.
It's not until you get those 3 things done, especially when you're flying a little bit blind, are you going to be able to kind of safely solve for the broken systems that we just talked about.
Mm-hmm. Yeah, there's a lot behind the scenes that we don't realize, and it's really become more apparent, unfortunately, with some ill results. Chris, in light of this, in terms of COVID or in general with the increased emphasis on digitization of healthcare, what changes do you see healthcare systems and hospitals making? I mean, I know that there are now a lot of new roles at hospitals to protect the security, cybersecurity, new skill mixes in the IT department. Can you tell us a little bit about how hospitals are starting to see the need and react, and what clinical areas are adapting digital transformation more than others?
Sure, absolutely. I guess I would start, we talk about digitization of healthcare and new methods of engaging patients and maintaining public health. I think for every organization, whether it's provider organizations or payers or IT vendors like my company, maintaining trust is just absolutely critical. And collecting and managing healthcare data is sort of, and doing it in a secure fashion that is, that is worthy of the trust. Genevieve touched on HIPAA and the tools, sort of compliant to the tools that we use for that. It's just really critical. And, as we think about, all of the tremendous ways where we could leverage data to do different things, we just need to continue to think about the bigger picture of sort of, whether we should, not just whether we can. In terms of change, it's the fire is very hot right now. The pace of change is likely to just accelerate, right? We've got in addition to the public health crisis, we've got an economic crisis and a recession that is healthcare led. Sunil talked about the elective procedures being canceled. This had a huge impact on the bottom line of these health systems, and it's not all played out yet. In terms of the changing human capital needs, a few things there. I think migration of data to the cloud brings with it a need for new different types of engineering skills, orchestration of containers, and coordinating, agile processes. You need process managers for that kind of stuff. You need risk managers for the data, again, maintaining the trust, right? So whether that's the information security officers and that type of resource, compliance managers and training people to train, how do the human resources within the company understand the data and how to protect it, which is where a lot of gaps often lie. In data science and sort of, I think you mentioned predictive analytics, there's skill sets there. And then importantly, I think as we engage more via telemedicine, like this user experience concept is really, really important, right? So that's another sort of, I think that's going to be a more valuable skill and resource, to answer your question on the, on human capital. I'd just say one more thing, in terms of, the coordination. I think Sunil touched on, sort of what the work that's happened in the DC, Maryland area by way of CRISP and sort of the data sharing. It's happening around the country as well. And it's really, enabling more efficient, more effective care delivery by way of coordinated resources is increasingly important now. And we can do more with the tools that we have. And we're seeing that, and it's exciting. So.
Great. Yeah, it's really interesting to we were already on this trajectory towards digital revolution, and now it's happening before we knew it so quickly. Genevieve, we talked before about all the new privacy issues, and security issues. Do you think that legislators and overseers are really doing enough to adequately address these?
No, would be my
That's
answer.
a short answer.
You know, GDPR, oh gosh, I have to remember the acronym. I'm just going to shorten it to the European Union Privacy Legislation, which is GDPR, General Data Privacy something. They acronymize things too. You know, that passed like years ago at this point, like 3 or 4. And it was a major overhaul of the privacy legislation within the European Union, which, by the way, already had the concept of people owning their data, which we do not have that concept within our current laws. It is frustrating because technology has been advancing at an incredibly fast pace. And the law that we have on the books that guards our privacy is from 1996. I was like, I think in high school at that point, which maybe gives you an idea of my age. But like, think about how much technology has changed since 1996, and we have not kept up with that, right? Like, so I think the issue is that we need an overarching privacy framework that allows us to have as much control as we possibly can over our own data and gives us choices. I mean, at the end of the day, like, we just don't have a lot of choice, right? Like, if you want to use Facebook, you give up your data. Like, that's you're paying for the service with your data, and we don't have those kinds of choices. And I've talked with legislators about this for clients doing educational services on the Hill, and like, they're all concerned about it, but there's no agreement about where you draw the lines over businesses and the things that they need to do to stay in business and where our privacy starts. And I think particularly within healthcare, you know, what started to bring this to light, and, you know, this is policy I worked on when I was at ONC, is getting patients access to their own data. So I'm a strong proponent in patients getting access to their data. I've talked before during my tenure at ONC about issues my family has had and health problems that have occurred because we couldn't get access to our own data. And I'm one of those weird people who, like, I check my lab results before my doctor does. Sorry, Sunil. I know doctors hate that, but I have hypothyroidism.
I have no problem with that.
My doctor doesn't either, which is great. But I have hypothyroidism, and it's a condition you have to manage or you get very sick. And so I know what my condition is, and I check my lab results and I stay on top of it. And so I'm a big proponent of that. And so is this administration, and so is ONC and the current leadership. The flip side, though, is that in getting patients that access to their data, we're going down a path of doing that where app developers who are not governed by HIPAA are the ones providing that access, which sounds fantastic because you can get it on your phone or your iPad or wherever you want. But most patients aren't, and none of us, to be fair, none of us read the legal agreements when we download an app. We just hit accept and we move on because they're legal agreements and they're really hard to read. So most patients are accepting that and using an app and having really no protection over their data. Like, once an app has your data, they can do whatever they want with it. They can sell it, they can use it for marketing, they can put it to a clinical trial, like, they can do all kinds of things. And they've built their business models fairly enough around like what they do with that data, right? Like every other business with data, they make their money off of the data instead of charging patients for using the apps. And so we have this like clash that's occurring and this false dichotomy that's been set up that like those of us who are concerned about the privacy somehow don't care about patients having access to their data. When I really want patients to have access, I just want to give them a choice about what then is done with their data. And so there are some companies out there who are really good actors who are using networks like Commonwealth and Care Quality to get patients really easy access to their data, and who are doing it in a way where patients have significant control over what happens, and they have to provide consent before anything's done, whether it's marketing or selling. And then we have like the whole crop of people who are not good actors and who are definitely making a ton of money off of patients' data. And that alone is bad, but like we talk about the future of our healthcare system, when you start to think about the subversive ways that we can be marketed to by our data, which the New York Times, if you've not seen it, has this whole privacy project that's fantastic. Like they've done a ton of research into how our data gets pooled and then how it's used in really like like behavioral economics type ways to advertise to you and get you to do things. It's fascinating because I love behavioral economics, poli-sci person here, so it's great. When you think about like combining our health data and the amount of subversive type marketing that you can do, I don't know how that doesn't ultimately just raise the cost of healthcare within our country, right? So there are like these downstream impacts to our entire healthcare system and to our economy that we just don't think about around getting that data out and what people want to do with it. And so I'm like deeply concerned that we are great job opening up data to patients. It's fantastic. We have FHIR APIs that make that really easy and I can get access to that data. But we also have this issue of now this data is out in the Wild West and patients don't know that and they don't have a lot of control over it. And there are downstream impacts to that. Right. And there are a couple of folks in Congress who are deeply concerned about that. Like if you talk to some of the health committee folks and some of the, and their staff, like they're really concerned about it. They just aren't doing enough to actually fix the problem because they just keep, you know, per the usual, like the two sides are hitting each other and can't agree on anything. And so it's really concerning. And, you know, part of the work that I did while I was at ONC was the Trusted Exchange Framework and Common Agreement, otherwise known as TEFCA, with the goal of connecting together all the health information networks across the country, which is not as much a technical thing as it is legal and policy stuff. And so the goal with TEFCA was to set the policy rules that we all agree to that allow us to connect. And part of that was making sure that apps who are outside of HIPAA have to follow some of the same rules and give protections to patient data. And we're dealing with it. I co-chair the care quality work group for policy for FHIR, the FHIR implementation guide we're putting together. And we're dealing with the exact same issues. Like everyone is deeply concerned about this, but we don't have like really great answers around how we make sure that like it is the patient getting their data and then it's not being used in ways that the patient doesn't understand.
It's really a work in progress. It definitely is.
It is, but we're also like maybe getting behind is part of the problem. Like the train has left the station and we're still sort of standing on the platform thinking, like looking at our watches thinking, when's it time? I don't know.
So Chris, I want to ask you, forget privacy, but there's so much data out there. I have a little quote in front of me. It's data is the new oil. It's valuable, but if unrefined, it cannot really be used. It has to be changed into gas, plastic, chemicals, etc., to create a valuable entity that drives profitable activity. So data must be broken down and analyzed for it to have value. So Chris, do you think that hospitals are really using all the data that they have as effectively as they can?
I mean, I'll go back to the question. I mean, like the setup to the question, you know, for data as the new oil, I would definitely want to just return to this concept of, you know, trust and maintaining trust. And these hospitals, health systems in particular, they are trusted entities. They're trusted institutions, you know, and they have robust IT and compliance organizations to help ensure, you know, privacy and security of their data. Smaller folks are typically outsourcing that function. In terms of are they doing enough with the data? Could they do more? Yeah, and it's exciting, right? I mean, it's you know, the opportunity. I mean, we've got to improve data quality. We've got to walk before we run in terms of that function. But you know, I'll tell you what, like there's a paradigm shift in healthcare that's been underway for a number of years, but it's only accelerating, which is this shift in policy and technology to enable, you know, sort of patient-focused care delivery and improve the outcomes in public health, as opposed to fee-for-service, let's churn out another procedure. And those are massive shifts in an entire industry, a huge industry, that are very exciting for companies that like ours that are enabling, you know, are enabling that transformation by way of digital health and care coordination. But yeah, I mean, just layering on predictive analytics, layering on, you know, emergency response capabilities and public health functions, and leveraging the data in ways that are worthy of the patient's trust, I think there's just tremendous opportunity there. And
it's really exciting. So we have to think positive that it'll be all used for the public good, and I have faith. So I want to pivot a little bit, and Sunil, I'm going to throw you a question, and then pretty soon we're going to get to some of the questions from the audience. But Sunil, we've talked a little bit in preparation for the call about behavioral health, and what challenges have you seen because of COVID-19, but also do you find that patients or the general public, that they are embracing remote ways to interact with therapists more and more? Do you think that's really taking hold? Maybe we've seen some of those ads with Michael Phelps for that mental health service. What do you think about that?
Yeah. So just to create a baseline understanding on behavioral health and mental health, again, in this country, is a lot of behavioral health, we have struggled to meet the demand with the supply. And there's a lot of reasons behind that. So when we think of behavioral health, we think of social workers, psychologists, psychiatrists. There's a whole spectrum that falls in that category. And we've always struggled in many parts of the country meeting the demand with our supply. Frankly, a lot of behavioral health specialists and providers may not decide to participate with insurance companies because they have a very successful out-of-pocket business. So in a lot of cities, that's one problem. The second problem is there's just not enough supply of them. There's a demand for that need. We know even before COVID, the behavioral health issues, for a myriad of reasons, technology, privacy, many of the things we've talked about, political struggles, non-political struggles, all of the above, the stress level and anxiety levels were already growing up pre-COVID. We saw that in the data. I see to put things in perspective, in the ER pre-COVID, a third of my patients had behavioral health issues, whether it's related getting to a prescription, a refill on a medication, feeling anxious, all of the above. And no immunity of age, meaning kids 5, 6, 7, all the way to seniors. So we already had a pervasive problem with a short supply. Fast forward to COVID, and it's created a whole set of new stresses on our population. It was so abrupt, so fast, so unexpected that all of those conditions that people had just got amplified, okay? So not only do you have this, and then you have folks that may have had latent stresses that just became double down. And then you complicate this and you shut down the healthcare system to some of these basic needs. We've seen a 30 to 50% increase, and this is a payer thing all across the country, in prescriptions related to behavioral health conditions. There's a tsunami that's already started in behavioral health needs, and people are scrambling, calling their primary care doctors. I've gotten a ton of calls from secondary, third, tertiary folks that I know. Can you assist me with this? You can see clearly firsthand that and the data is showing there's a struggle. Telemedicine has been a huge opportunity there. All of our telemedicine visits nationally have gone up for physical disease, but behavioral health accordingly. We like that. We want people to get access because there's a direct connection between your behavioral health connection and your physical diabetes and your physical asthma. You are more likely to take your medications for diabetes if you have your mental health needs addressed.
Right,
So
right.
not rocket science.
Right.
So telemedicine has been a huge resource. Digital applications, you may have seen commercials for a number of where there's a tree and it's raining and they said, stop what you're doing and watch this for 30 seconds, right? I've seen a number of these companies that we vetted for a long time that are now, I'm finding myself watching this television commercial, looking at the rain coming down.
Calming, yeah.
To break from my
Commercial for them, but yes, a little bit calming.
So I do believe behavioral health resources through digitalization, behavioral health, telehealth are going to be a big part of people adapting to a new way of seeking care that they couldn't in light of already the shortage that we've had before.
Great. Yeah, it's really wonderful that we can increase access that way. So there's a lot of silver linings here for sure. So now I want to get to some of the questions from the audience. We've gotten quite a few. One thing I want to kick off with, I know I had this question as well, but I wonder what has University of Pennsylvania been doing to help in the COVID-19 crisis? And I think Chris might know a little bit about it.
Sure. Yeah, and I did a little bit of research on this. Can't claim to know everything that's going on there, but you know, I'm aware of a few activities, especially at Penn Med. You know, I think some of the things that Sunil was touched on early, you know, remote patient monitoring, telehealth, hospital at home, they're doing those things for sure, fully embracing them. They accelerated their deployment of contactless registration. So you can complete all your forms on your phone before you ever get into a facility. They've got their innovation center mobilized to develop new technology platforms, and they're doing, you know, a bunch of you know, interdisciplinary efforts in the interest of de-risking the future. You know, it's exciting, and there's a lot of really smart people there. So very excited to see what comes out on that front. The hospital at the university, they accelerated the completion of their new tower in response to the crisis. I think they enabled 120 or 150 new beds, which can function as ICU beds in a surge. I think as of last month, the facility being tested with actors to sort of walk through for COVID safety, ensure low touch containment of the virus. Also learned they're actively working on testing, you know, and therapeutics and vaccination. So they have made some really great progress on saliva testing. So instead of like nasal swabs, you know, they're able to do these saliva tests which can provide results in minutes at a very low cost. And the idea here is you'll eventually be able to just do this at home. And that could be really, really helpful. This work's happening in partnership with the engineering school. I think they would say that. They're making some progress on antibody testing. They're supporting at least one vaccine that's in, I think, on its way to phase 2 of clinical trials as of a few weeks ago. Maybe it's still in phase 1, but and then they're excited about the therapeutics. So, you know, I mean, we haven't gotten a vaccine for AIDS yet, you know, so they're still concerned that we aren't going to get a vaccine soon, but they're making a lot of progress with therapeutics. So they've got their gene therapy infrastructure mobilized, and they're testing an approach called the BioShield that involves you inhale an antibody, and so they'll know in a few months if that approach works. And then one other thing that I thought was just kind of interesting, the vet school is working to train dogs to smell the infection. So, you know, that's kind of like, I just thought that was kind of interesting. So,
yeah, it takes a village.
Yeah, so they've got some stuff going on.
Wow. Thank you, Chris. Yeah, it's really exciting. And for everyone on the call, if you're interested to know more about the clinical trials that Penn is involved with, they're listed on the Penn Med website, and they describe each one, and many of them are still accepting participants. So it's real interesting to track that. There was a webinar that Penn Med put out that updated us on what's happening, and they do those from time to time too. So I have a few more questions here. Here's one about, I might throw this one out to Sunil. What do you believe will be the greatest implications of this accelerated digitization on senior care, particularly for seniors at home?
That's a good question. So one of the areas the telemedicine industry has always thought about over the last several years before this inflection point was the adoption of telehealth solutions by the senior population. I oversee the Medicare business for our population here, and what we've seen, which is characteristic of many Medicare businesses across the country, is anywhere from 30 to 60% adoption of telehealth visits by the senior population. So that myth or that confusion, and this is not characteristic of us, the industry has seen a tremendous adoption on seeing a doctor through video or even telephonic, because even the legislation and policies for now, and I think Genevieve brought a good point, it'll be interesting to see what stands as the dust settles. But even telephonic visits, for the most part, have been covered, which was nobody thought about a telephone call being covered as a reimbursed visit. All of that is being embraced very well by the elderly and senior population. And I anticipate that will continue and ramp up post-COVID. Now that there's a comfort level, and the other part of the equation is the technology has gotten easier to use. When I got into telemedicine in 2011 and 12, the technology was clunky. The bandwidth wasn't there. And there were a lot of limitations. Now, with the relaxing of limitations for us to experiment during this COVID crisis, and then with the ease of the technologies, all generations are using this simply to get care or just to socialize.
Yeah, I could tell you firsthand, there's a lot of family members helping behind the scenes there, but I'm really glad to hear that. Yeah. I guess it's forced people to get over their fear of technology in some ways. So that's true. So here's a policy question. Maybe Genevieve can answer, or others can chime in. Has there been an increase in multi-regional health information exchanges that span more than one locale?
Not really. I think, those types of arrangements require significant work to put in place, both from a technical perspective, because you have to agree on the standards that you're going to use, what data you're going to exchange, but also from a policy perspective, because you have to agree to who can access the data, what data are they accessing, how are we going to make sure that it's the right patient and do the patient matching piece of things. And so with a crisis like COVID, you can't really move fast enough to suddenly have like an increase overnight of those types of arrangements. They are happening generally, right? Like the industry's been moving that way, and SHIC, which is the Strategic Health Information Exchange Collaborative, with their Patients Under Data Home project called PCDH, and the notifications they do, like they've been moving towards that type of multi-regional structure for a while, but it's not like you suddenly like COVID hit, now let's like all agree to work together. And totally biased in this, I will admit, but the trust exchange framework and common agreement is meant to allow all those organizations to connect, whether they're national or regional, and allow that easier access to data by solving the policy problems and agreeing on the technical standards. And so I will say what we've seen speed up, since this is not that regional collaboration, but like some of the TEFCA work that's still being done has sped up, like, so they've modified their timelines. And then within care quality as a network, what sped up for us was the FHIR implementation guide work. So, and I'll give credit to AI on this one. AI has been working on a project called SANER, which, Chris, I have no idea. I can't remember what that acronym stands for, but the goal of it is basically to use FHIR APIs to pool the like administrative type data from healthcare systems around like number of beds available, what PPE equipment do you have, like all that sort of data that we haven't been able to share in order to deal with like the overwhelming population that suddenly a hospital gets, right? So they could share equipment, that kind of thing. The SANER project is building the FHIR APIs to enable that data to be exchanged more easily so that we could better manage like the next wave of things. And that work around SANER accelerated our FHIR work so that you could actually do this over a network. And so our implementation guide wasn't supposed to be done until the end of the year. It's done this month. So we moved it up by 2 quarters, which is really hard to do with a work group of volunteers. But we're seeing like that type of fast work where like we already have a lot of the technical components, but we're missing some of the components we need for some of the data that we need. And so that has accelerated pretty quickly compared to what it normally would be. And that's honestly just due to folks being willing to volunteer their time to build out the implementation guides. And then frankly, again, we have to deal with the policy around that because not everyone thinks that that data should be shared with everyone because it's not always accurate. And so there's like some inherent issues there. But that, I mean, that's sort of what we're seeing is like some of that work is accelerating, but there's no, to my knowledge, no new regional partnerships that have gone into place since COVID. I think really just people are continuing the work that they've been doing.
Right. Got it. Okay. Cross our fingers.
Yeah.
Yes. So Chris, here's a question for you. We're getting so many good questions. So here's one. We've been talking about AI and medical systems interoperability for 20 years. Can you cite some clear successes for the use of AI in addressing the problem of the lack of interoperability, especially with legacy systems?
Sure. Regarding, let's separate interoperability and artificial intelligence and AI audacious inquiry. So, I'd love to talk specifically towards interoperability and the specific successes there. I mean, we've got 98% of all of the hospital beds in Florida wired up, and the enabling primary care physicians, like the biggest one, right? So we know healthcare outcomes dramatically improve when a primary care doc or a care team is alerted when a hospitalization occurs. So if Mrs. Smith has an encounter, her primary care doc wouldn't normally know about that absent interoperability and an encounter notification. So when you have that notification, the primary care doc can call a patient, hey, Mrs. Smith, what's going on? What happened? Let's make sure, did you understand your discharge instructions? Are you taking your medications, after your hospitalization? And the outcomes that result from that simple intervention are just tremendous. And we're really it's not universal. It's not ubiquitous yet. It's happening in Florida. It's happening in Maryland and DC and Virginia, but it's still being worked into the processes. And the incentives are really important for driving that. So that's an example. Talking to, I think the question also asked about sort of artificial intelligence. Like, this is where I'm like, look, you need to walk before you run. We need to walk before we run on this. Like, we can use artificial intelligence and machine learning to improve data quality, and that's where I see a lot of value. I hear, predictive analytics, there's opportunity there, particularly, I think I'm excited about it in the social determinant space. In imaging, I think they're making a lot of progress in imaging. There's some work with chatbots and triaging using artificial intelligence, but I don't have as many specific examples for how we've improved care quality and cost using artificial intelligence as I would for interoperability and sort of the tremendous potential impact there in a very short time.
Mm-hmm. So we're getting there. I guess we'll have to reconvene in 5 years and
see where artificial intelligence is. Yeah.
Everyone out there. So it was interesting. I myself attended the HIMSS conference, Health Information Management, and I heard a lot of interesting applications of digital healthcare. The CIO of Cleveland Clinic, he talked to us about how basically his life was saved, and he was running in the New York City Marathon, and he thought he was gripping onto his bicycle, actually it was a triathlon, his bike handles too hard, but he was actually having a heart attack, and he told us the whole story, but he lived because he was able to share files between the mobile health van and a shock trauma center, so that was one thing. Then we heard something about robots in hospitals, like there was Moxie, who is a robot who carries supplies and dirty linens, I believe at Columbia Presbyterian, and some of the kinks are still being ironed out there. For example, dealing with Otis the elevator, getting onto the elevator. Alexa in hospital rooms to help patients to turn lights off and so on. Advanced nurse calls specific to a particular nurse, not just a nurse's station. So I want to ask Sunil, what is the most interesting or unique application of digital transformation that you've seen at a hospital?
If it's okay, I'm going to get to that in just 1 second. I'll definitely going to get that. I wanted to make a comment after Chris spoke that I think it's important to kind of summarize everything we've heard. We've talked about really positive uses of technology, like one I'll demonstrate in the hospital, like you asked me, Lisa. And then there's the negative of the advancement and the speed in which we are sharing data and doing technology. And I agree with that phrase, we need to walk before we run, because people are talking about AI like it's here and there, and we have droplets of AI working in certain places. But I always tell my teams, I deal with a lot of data from the hospital side and the payer side. It's an inundation of data. And I always say garbage in, garbage out. If you give me garbage data, my actions on that data will be an output of garbage. So what relevant pieces of information do I need to do something that's impact oriented is something that I really beat on. And I have access to some of the smartest IT people at CVS Aetna that we think about what is the end point and then work backward in asking what are the types of data we need, which is not what really happens in a lot of parts of healthcare these days. And when you get the right data, then you can do what I call the trifecta of healthcare information. You know, you can do real-time care management, you can do predictive analytics, and then you can third innovate. But until you think about it in that format, we can't do any of those things. And I'm sure Chris will agree on this with all the data that he consumes in the work that he's doing. The problem is we have pockets of the country that are more advanced than other pockets of the country in these respects. As Chris mentioned, Maryland and DC, with his help, has made tremendous stride. Florida, there are pockets all over the country. But in the reality, this needs to go so top down to make an impactful effect on the citizens of this country's health. As I said earlier, as evidenced by the pandemic's effect on how we've responded in this situation. Now, in terms of the hospital, what are some great things that I have seen deployed? Telemedicine, I have to say, hands down, in this region, there are hospitals that were very advanced in telehealth, and there are hospitals that were behind. And I would go to those hospitals and say, you are behind. And without, and we, the fact of the matter is this relaxation of regulation, policy, adoption, all of the above, the desperate need to have care has made hospitals step up their programs overnight. And I agree that we have to be really careful about privacy and technology and all that, but it's a risk versus benefit type of situation. Like in many cases, it was life or death for some people, behavioral health, physical health, to have access to a video doctor or a telephone doctor. So the fact that I think that has been one of the extraordinary positives that have come out from all the hospitals I practice in certain hospitals, I administrate in other hospitals. I have seen an unprecedented positive expansion of virtual care services that I have applauded all across the board that will stay in many forms. So robots in the hospital, it's great. EMRs getting more connected to public health departments, that's great. But I think if you pin me down on one thing, it's telemedicine and virtual care at all levels.
Great. Yeah, I agree. It's really a wonderful thing that we have at our fingertips. So here's a question that is more important these days than ever, and it's about how the pandemic has highlighted the longstanding health disparities in minority communities. So can the panel speak to areas where we may have fallen short in responding to the needs of these communities? For example, the lack of broadband for telehealth, not reporting data by certain demographics, and how do you think we can do better? Maybe each of you can speak briefly to this. Sunil, do you want to say a few words and we'll move on to Chris?
Yeah, I think that, as I mentioned earlier, our health departments were never really as recognized as they are now. And there are a number of very interesting technology-based healthcare companies that have gained a lot of traction before COVID that leverage community resources. Unite Us, namely, I have no affiliation with them, but I've seen wonderful work that they've put together. And other organizations that have looked to tie community resources, whether they're YMCAs, health departments, all of the above, in underserved areas, and provide connectivity between those community resources with healthcare providers and payers like us, to be able to make sure our members have other access points besides hospitals and doctors to care for their needs. So I've seen the emergence of those kinds of things. But it's a great question, and I'm sure a whole new set of resources, companies, and assets will develop. I know CVS Aetna's working on building resources in those communities. We've learned from those situations as well.
Mm-hmm. Yeah, anyone else want to chime in on that, Chris or Genevieve?
Sure. Thanks for the question. I mean, I think that the current crisis, you know, the economic crisis as well as the public health crisis has been absolutely devastating for underserved communities and for people of color. And I think it's frankly underreported. And, you know, in terms of the opportunity, I think it's tremendous. You know, digital health will play a part, but it's, you know, it's all the things. It's, you know, it is meeting the social determinant needs, right? Like the things that are driving the poor health, nutrition and housing, and getting those targeted and applied, you know, as efficiently as possible. You know, I think the crisis is going to accelerate that work. There are, you know, in terms of the tech, you know, there are companies, there's one that I'm familiar with and invested in called Socially Determined, based in DC, it's in our region, that is doing the analytics to help target resources for the underserved communities. You know, I mean, telehealth, like as much as we say broadband's not available, you know, cell phones aren't available, they are actually fairly available from the, you know, the research that I'm familiar with in communities. So like, you know, there is some enablement for, you know, I think the telehealth transition, you know, mental health, behavioral health via telemedicine, you know, that could provide some opportunity here in terms of the application of tech. But I mean, personally, I'm concerned and you know, intend to develop, you know, sort of continue to devote some of my personal time and you know, philanthropy for what it's worth towards this effort, particularly on the nutrition and social determinant side.
Mm-hmm.
And I would just add in, I think, you know, there's two issues on that. One, the payment models that we've traditionally had don't lean towards making sure that you have nutritional sources and good housing as part of like the overall health. The new models, I think, emphasize that more, certainly with accountable care organizations, some of the bundled payment models, though I think none of us totally know what's going to happen with them now that everything is sort of changing so rapidly. But certainly the traditional fee for service does not incentivize dealing with those other social determinants of health. And then, you know, the other issue we don't talk about a lot is Medicaid is certainly prevalent in those communities. And there's two issues. One, the IT systems that the Medicaid agencies use are, I mean, like old as dirt. Like they're just like, there's not like the way that gets funded and the way that those systems are developed, and frankly, the monopoly of the companies who run the Medicaid systems, because there's only like 3 or 4 in our whole country that run like all of the Medicaid IT for the various states. Like they're not good enough for what we need to be able to do with data to actually fundamentally like take a population health type view of that Medicaid population. And there's work being done at CMS to change that. A former audacious inquiry person, Julie Bond, is like working on that and making things modular, but like we just aren't doing a good job with that. And then they have another issue, which is a workforce problem. So like their IT is really old, and oh, by the way, the people who know how that IT works are like retiring. And so they don't have enough people to even do the work they need to do. And so you kind of have like all of those issues coming together to mean that that population, particularly in the urban areas, like just isn't necessarily getting the services that they could otherwise get. So it's a multi-layered issue. I don't think there's any easy answers.
Thank you for your perspectives on that. And I have a follow-up question sort of related to this. Maybe it's for Sunil, but are doctors and other providers incentivized to proactively check on patients based on their notifications, say from remote devices, or other information they receive from data? Are they getting paid for every interaction this type? This person doesn't think so, and what's the reality of what's going on out there?
Sure. So if I think I understand the question correctly, are doctors getting paid for the interactions they're doing? So still
after the fact,
and following up.
Yes, when they receive some kind of inputs from remote devices,
okay,
or what have you. Yeah.
So there have been a number of codes over the last 12 to 24 months, even prior to COVID, that encourage remote patient monitoring reimbursement for that kind of visit. Are doctors jumping and swarming on that type of care? No. No, it's a small fee, anywhere from $30 to $50 a month for monitoring a patient for a chronic disease, and it has its own code. So what Genevieve was touching on is, I do think we engage in a lot of value-based contracting, and we don't just say it. The reason why I mention it like that, a lot of insurance companies say, we're doing value-based contracting, we're paying for outcomes. And what that essentially means is, you pay a doctor or a hospital for a visit like you normally would. But then at the end of the year, if they've saved on certain outcomes, like you've improved their diabetes, you could be improving their mental health, then you get an extra bonus check, okay, for keeping people engaged in the wellness of their condition. So because we are a joint venture between Aetna and providers in this market, we're able to engage in more value-based outcomes types of contracting than the typical type of payer. I do think you're going to see more of that construct as a result of the pandemic, because outcomes, that's accelerated. Outcomes, people's physical conditions are going to deteriorate. We're seeing it because they're not seeking care. There's going to be a lot more pressure on providers and payers to deliver a healthcare system this country's been asking for a long time, which is, keep me healthy, keep me well, don't treat me after I get my cancer or after I get my heart attack. Help me get through this. I think there's going to be a lot of pressure on all of us in the healthcare industry, the policymakers. I did a lot of work with the Affordable Care Act. I mean, this pandemic is going to move a lot of discussions we had then much faster than it was then. Interoperability, absolutely interoperability, I think is going to go faster than it did pre-pandemic. So, I think that doctors will get paid more for the services that promote those outcomes and not just episodic care, if that makes sense.
Right.
I'd add to that, like, just in response, like one of the things that was introduced, I think, as Sunil mentioned a couple of years ago, particularly for Medicare patients, was this transitions of care management, TCM, CPT code that, frankly, a lot of providers probably are not aware of. But this was an attempt to drive, value-based care on top of a fee-for-service chassis. But it's this idea that a primary care doc or a practice, they call a patient after a discharge. So if one of their patients has an encounter, they weren't otherwise aware of it, now they're aware of it because of interoperability and a notification, and they call and get their patient in for a post-discharge visit within 7 days or 14 days, depending on the severity of the hospitalization, they get paid for the visit, as well as an extra kicker for doing it in that time frame. And so it's good for the patient, it's good for the practice, and in the long run, it saves Medicare money because the outcome is going to be better in the long run. They're less likely to get readmitted to the hospital and have further complications. So that kind of thing is happening, and frankly, it's not that widely used yet.
There we go. We're almost approaching our time, and I had no glitch until just now. I want to ask one more question, and then we're going to wrap up. And this question is for Genevieve. So there's an abundance of health apps on the market now, including mental health, but little guidance to help patients decide which are actually effective. Do you see any groups like the FDA or insurers who are stepping in to vet apps for clinical use?
Yeah, so it's an excellent question and a problem. So the Carin Health Alliance, CARIN, they just about a week ago, if not a little bit longer, announced that they're setting up that type of vetting process. So they're going to have like their version. I don't want to call it an app store because it isn't like you go to their site. It's not like you're on your iPhone and you go to like Carin and it's like an app store experience. But it is that concept of like vetting apps against like their set. So they've put together a set of principles that apps should follow around like what they do with the data, how they protect it, things like that. I think it's called a code of conduct. So they just announced that they're putting that together. And I think there's about 6 to 8 apps that are in the first round. Not all of them are apps. Some of them are more like the traditional, like Citizen is, I don't know if Citizen has an app or if they're the more traditional One Health Records in there, and I think a couple others. So they're working on that. I think the inherent struggle that we have is the policy that ONC put forward while I was there, so I guess it's partially my responsibility. Like the policy that they put forward, the rule is that a healthcare system can't say no to any app that a patient brings in, right? So a patient could walk in with an app from like Russian hackers and want you to send their data to it, and like you have to do it, right? Like that's the rules under HIPAA, that's the rules under ONC information blocking. And so we have like sort of a system where there, like you can't really vet apps except for security issues that would impact you from a HIPAA perspective, right? So like a healthcare system can say no because you didn't identity proof the individual, right? Like that's a HIPAA requirement, have to do it. Or if they think like you could hack my system, but a read-only fire API, that doesn't really work. And so you almost like, there's no incentive for apps to actually go into a process and be vetted because the healthcare system and or vendor, whoever holds the data, can't say no to them if the patient is the one making the request. And so we have this sort of, again, weird situation where like Carin has set up a great process to be able to evaluate these apps and give some feedback to patients that would help them make good decisions about which apps they use by just knowing sort of the principles about that app. But there's no incentive to make the apps actually go and use it. And so, I guess maybe this is just my persnickety personality, but like if I'm an app developer and like I don't have to follow rules that might not benefit me financially, like why would I follow them? There's just no incentive.
A lot of work still to be done in this area.
Yeah. So I think like there's at least 1 or 2 other organizations who are trying to set up that same concept, but Carin is like the best known in our industry. And I'm not sure that they're evaluating for things like the clinical efficacy of a particular app, right? Like we definitely don't have that, right? Like we have an evaluation of what will they do with my data? How will they protect it? But whether or not a particular app is helpful to like help you quit smoking, help you with weight loss, like I don't think any organization is really doing that level of analysis. And I don't know that like, and Sunil would know better, but I don't know that the medical community has done significant study yet on those apps and like long-term efficacy of them. I think, they're all built off of behavioral economic principles, so they should work, but who knows?
Yeah, we're really approaching the end of our time. There's so much that we could talk about. We'll have to have a follow-up sometime. But I would just want to wrap up. Maybe each of you can go around with just a few words, a soundbite, as to what is your greatest hope for the digital revolution of healthcare. Genevieve, while you're up.
Sure. I think my greatest hope is that this pushes us to solve the basic underlying foundational issues that we have just thus far in our industry failed to address. Like the unsexy, uncool stuff, like patient matching, provider directories, like that we just have failed to fix. I'm really hopeful that this pushes us to fix those issues because we can't really build digital health systems on what we have now.
Mm-hmm. Chris?
Sure. Yeah. I mean, I'd echo that. I think building on the systems we have is great. I'm really excited for acceleration of the transition to value-based care and sort of patient-centered care. And I believe that providers will remain at the center of that, and not necessarily, I don't think all care is going to be delivered by apps and artificial intelligence. But I'm really excited for that transition to continue, and for American healthcare to realize the promise of the investment that's being made there.
Mm-hmm. Great. Yeah, and Sunil, do you think that people will continue to embrace the telehealth even after the pandemic passes, which we hope for?
Yeah, absolutely. Yep. My hope is, as we finish up this conversation, is that applications, data transmitted through different kinds of portals, and even information transmitted through social media technologies are used in a way that help us and not hurt us. And I know that sounds obvious, but I lump data in applications, EMR data, insurance data, social media transfer of information, that we use common sense judgment and rely on expert sources to help us validate this data. And a clear example of that is CDC just put out information this week where 1/3 of Americans are using disinfectants and cleaning agents incorrectly by either bathing, drinking, and that's scary because that's a data source that has been transmitted through technology that has been inappropriately used, just like any other data source. So I hope we use common sense and rely on experts to be able to decide which apps, which data we use to really help and advance our health, not hurt our health.
Mm-hmm. Yes, I second all of those. Really great thoughts. So at this point, I want to respect everyone's time. And again, maybe we'll have to do this again. And I really want to sincerely thank all of our panelists for their time and valuable insights, and all of you for joining. A recording of this webinar will be placed on the Penn Club of DC's website. Might take a few days, but look for it soon. And please share. So thank you so much for joining us. And stay tuned for more great programs for Penn, Wharton, and Columbia Clubs of DC. And everyone stay well.
Thanks, Lisa.
Thank you. Thank you.